Hey everyone, welcome back to Urgent Care Stories. Today's episode is episode 10, and we are going to be talking about one of the most common complaints that you'll see in your urgent care, ER, or primary care settings. That's the common cold, the flu, the COVID type patient. I wanted to just spend a video explaining kind of my thought process as to how I come to the right diagnosis, what I need to rule out with people, what signs and factors I'm looking for each of these subtle different conditions, and lastly, what I'd recommend treatment-wise for patients and kind of some of the recommendations I give. This is not medical advice, so if you are a patient, I don't know your unique medical history, your allergies, your medications, so please follow up with a medical provider if you're looking for specific treatments on things. Let's just begin with kind of the common complaint that comes in and then how we're figuring out what the differences are between each of these conditions. So somebody's going to come in and for a common cold, not a flu syndrome, not a bacterial infection, just a viral upper respiratory infection, you're typically going to hear a story of 1 to 5 days of symptoms, sore throat, stuffy or runny nose, a little bit of a cough, maybe headache, sinus congestion or pain, that sort of stuff. With a common cold, you're typically not going to see a fever. You're not going to see muscle aches, body aches, and you're typically not going to see like the myalgias and the kind of rapid onset that you would see with a flu syndrome. Most of the time with an upper respiratory infection, I'm just making sure I don't see signs of bacterial infection. So a sinus infection, meaning an infection of the frontal or maxillary sinuses, typically we're going to have a worsening of symptoms after day 7 or 10 plus days of symptoms with pain, pressure, and thick mucus coming from the sinuses. So when those patients come in and they're on day 1 or day 2, I can guarantee you it's not a bacterial sinus infection. That person does not need antibiotics. What do we do for just a simple common cold? Well, we treat the symptoms. Most of the time, these are caused by coronaviruses, adenoviruses, parainfluenzas, lots of just different viral strains. And there's just a couple that are predominant every year. Everybody gets these. I'm just getting over one myself right now. I manage the symptoms. So if I have sore throat or pain, I'm alternating Tylenol and Motrin, and just making sure that you're dosing it frequently enough to make sure that they're controlling the symptoms. If they're having stuffy nose or sinus congestion, my favorite is to go to an antihistamine to dry up some of the production in the drip, a Flonase or Nasacort nasal steroid spray to help dry up the production as well and keep them breathing a little better, and then a decongestant like a phenylephrine or pseudoephedrine to dry up the congestion. So my favorite would be like a Claritin D or Allegra D plus Flonase or Nasacort for the nasal congestion component. If we're having sore throat, again, that just goes right back to the Tylenol and Motrin protocol. You can also use viscous lidocaine. That's a numbing medication they can gargle with in the back of the throat. And then for cough, just any of the over-the-counter cough medicines, Delsym, Mucinex DM, anything like that. You can increase prescription to like a benzonatate or Tessalon Pearls. Sometimes I'll use a Bromfed cough syrup or a promethazine cough syrup with dextromethorphan. They're all basically the same, and it's really just finding the right protocol for the right patient. A lot of times patients have not tried hardly anything. They've just done like tea or vitamin C. And in that case, it's fair to start with a conservative approach because you're probably going to help improve their symptoms. Things that I would be looking for a bacterial infection. We already mentioned sinus infection. The other would be an otitis media, an ear infection. So when you're looking in the ears, you're basically just looking for redness, pus, and bulging of the tympanic membrane. If you see those signs, I think it's appropriate to put that person on an antibiotic, but I still try to do something to manage the congestion because the eustachian tube connects the sinuses to the inner ear, and that getting blocked is usually the cause of that inner ear infection. So if we can manage the production of mucus and get things flowing out of the inner ear, we can, one, alleviate the pain, and we can also reduce future likelihood of ear infections if we control that mucus. That's one of the reasons why kids get so many ear infections when they're young, is because their eustachian tubes are very horizontal, and they don't do a good job when they're 1, 2, 3 years old at managing their secretions, being able to swallow their mucus, blow it out, cough it up, that sort of stuff. So it just kind of sits there and grows out a bacterial infection. Strep is another one that you're going to see, and I typically follow the CENTOR criteria. So CENTOR is CENTOR. That's the findings that you're going to expect to see in somebody who has strep pharyngitis. Strep is more common in younger people, so you get an extra point on the CENTOR criteria if you're less than 14. You get no points between 15 and 44, and then if you're over 44, you actually get -1 point just for your age. We basically start testing if you have 2 or more of the criteria. We used to treat empirically 4+ or higher. They've recently changed that to basically just test everybody who has more than 1 criteria and then treat the people who are positive. I still kind of, if they're negative but it looks very streppy to me, I'll still treat them, or I'll send out a culture to confirm. So CENTOR criteria, C is for lack of cough. So with strep throat, they're typically not going to have a cough. So if they do have a cough, that is a less of a risk, but a lot of kids, for some reason, they do end up having a cough when they are positive for strep. So cough, lack of cough is the first one. Exudate is E, that's exudate or pus on the tonsils. So when you look in the back of the throat, you're going to see some white spots, some pus, something either in the back of the throat on the pharynx or in the tonsils themselves. N is for nodes, that's lymphadenopathy. With strep throat, they're going to have anterior cervical lymphadenopathy. If you're looking for mono, they're typically going to have posterior cervical, which is behind that sternocleidomastoid muscle. So anterior cervical lymphadenopathy, and it's typically going to be painful for the patient, so it hurts to touch their lymph nodes. So when you feel those lymph nodes, my next question is, does that hurt? And if it does, I consider that a positive risk factor. T is temperature. Most of the time they're going to have a temp 100.4 or higher is considered a true fever. 99.5 or higher is considered one of your low-grade temps. Everybody seems to think that they're different and they run cold, but across all of the data, that's kind of what we consider true fevers, regardless of who the patient is. That is kind of basically the criteria there. It's the fever, lack of cough, pus on the tonsils, painful lymphadenopathy, and then the age is the other factors. And we already discussed that. If I see enough of those factors, I'm going to do testing for strep, especially in a younger person, and then we treat accordingly. So that's kind of basically your strep infections, ear infections, sinus infections. So those are the 3 most common bacterial illnesses that will require antibiotic treatment. If you don't see any of those signs, or if they don't qualify with the CENTOR criteria, then you basically just say it is a common cold. If they are within the first 5 days of illness, I think it's appropriate to test for flu and COVID at least. And that can be done with rapid testing. It's pretty easy to do. Typically, if it is a true viral strain or viral syndrome, you're going to see a little more of a rapid onset. So with the flu, we're seeing a lot of flu A right now. With flu, you're typically going to see Thursday I was fine, and then Friday it hit me like a ton of bricks. Body aches, fevers, chills, cough, sore throat, headaches, feeling like I got run over by a bus. They're typically going to have a low-grade fever, and they're going to be tachycardic. Their heart rate's going to be up, and it's pretty rapid onset. You obviously want to check them for flu and also check them for COVID because they can present similarly. COVID is one of those where it can look like anything, so your common colds, it's appropriate to test for it. Your flu syndromes, it's appropriate to test for it. I typically am going to be doing testing within the first 5 days of onset. So if you come in and you're like, hey, I've been sick for 8 days, I wouldn't initiate any treatments differently if I knew you had flu or COVID, because you're outside of the window where we can do antivirals against those conditions. So really at that point, I'm just deciding, do we see a secondary bacterial infection? Do we see anything that we need to treat symptomatically? And are they looking stable on their vitals? So if they're within that first 5 days of illness, we do our flu and COVID testing, and then there are some antiviral medicines, Tamiflu, Xofluza, and Paxlovid that can all be used for those different viruses. We obviously discussed the kind of time frame of how long to expect to be sick and that sort of stuff, and that's kind of what we do for the flu syndromes. Again, it's all supportive care. The antivirals, if given within the right amount of time, just reduce how sick the person is and helps them feel better a little bit faster. The last condition that you see a lot of in the urgent care is that bronchitis, right? So the person's going to come in and they say, I got bronchitis. I need a Medrol pack. I need a Z-Pack. I need an inhaler, and I need codeine cough syrup. And you go, okay, no, you don't. Bronchitis is inflammation of the bronchus. So bronchi is just the air tubes in the lungs. Itis is inflammation or infection of. 99% of bronchitis is viral. Okay, so somebody is going to come in. Usually they're going to have the first few days is just your standard upper respiratory infection symptoms, sore throat, coughing, sinus congestion, that stuff. Then they're going to say, oh, it went down into my chest and it went down into the lungs. They're starting to have more of a cough. Typically with bronchitis, it's more of a dry, non-productive cough. When somebody's coming in with this, I'm asking time frame, how long. If they've only been sick for a few days, hey, I say let's let this run its course. If they've been sick for a couple of weeks, then I say, okay, let's consider other things. I want to rule out pneumonia. What does pneumonia looks like? Well, it's typically going to be chest pain when coughing, productive cough, shortness of breath, and fevers. You're typically going to see this in elderly populations or people with impaired immune systems, like people with COPD or smoking or, some sort of lung condition. But you can also see it in kids too. You're typically going to hear some abnormal breath sounds, but you might not. And so typically I'm just looking for those symptoms. If they start to say yes to enough of those symptoms, then it's just a chest x-ray to rule out a pneumonia. So I just snap a chest x-ray, take a look, and then we decide what to do from there. Assuming they don't have a pneumonia, bronchitis is self-limited. The frustrating part about bronchitis is that condition can last for 2 to 6 weeks on average. And they've done studies. They look at inhalers, steroids, cough medicines, antibiotics, you name it. They've tried everything in these studies, and they all find that there's no clinical difference in outcome. Bronchitis just has to run its course, and that's really frustrating for the patient, but that's kind of how it works. So that's kind of my spiel to the patient is I say, look, you don't have a pneumonia. I don't see any signs of a bacterial infection on exam today. This is kind of what this is what bronchitis looks like. This is how long it lasts. These are signs that I'd want you to come back for because that might be a pneumonia. And then I say, these are the things that we're going to try. I don't do steroids or an inhaler unless I hear wheezing or they're having some shortness of breath. Cough medicines, I try to combo up like a Tessalon or benzonatate with some sort of dextromethorphan-based cough medicine. Every once in a while, I've seen some benefit from azithromycin, but again, I think it's way overprescribed, and I think most people don't need it. So I try to use it on a very limited basis, but if any antibiotic is going to have any benefit, I do think that azithromycin does have some intraparenchymal kind of anti-inflammatory benefits for the lung tissue, and it does have some antiviral benefits to it as well in some research. Again, I'm not using it because it's an antibiotic because I think I need to kill bacteria with it. I just think clinically I've seen some benefits from it. Now, if you have a smoker, a COPD person who has an acute bronchitis exacerbation, we treat those a little bit differently. We are going to put that person on a proper antibiotic. We're going to put them on some steroids, inhalers, and stuff like that because they have a much higher rate of developing a pneumonia. And so if we've ruled out a pneumonia, we're still going to end up putting them on something and just looking for progression. But again, it's good to tell people these things can take up to 6 weeks to resolve. That's kind of the name of the game with how I approach these things. I'm looking at time frame, how long things have been going on, what sort of symptoms they've had. I want to know what they've tried already. And then I do the appropriate treatment for what I see and what I hear. I really try to fight people on not doing antibiotics because I think a lot of things do not need antibiotics, and I think they're going to resolve on their own. And there's this kind of myth where if I have a sore throat, I need an antibiotic, or if I have stuffy congestion in my nose, I need an antibiotic, or if I have a cough, I need an antibiotic. And we have to try to tell people that that's not the case. We don't need that. I think that it's hard when a lot of providers, they don't know what's going on and they just throw an antibiotic at it just to say, oh, at least I'm covering them for the worst case scenario. I understand that approach, and I think that there is a time and place for that, but I think that we really have to do a good job making sure we don't see the things that we're trying to rule out, the things that we're worried about. And sometimes it's even appropriate to say, hey, look, right now I don't see anything going on that looks bacterial, but I understand that you came into the clinic and most people get pretty pissed off if they aren't prescribed something. So I say, let's do some stuff that I think is really going to help manage your symptoms, make you feel better. And then if you're still feeling sick on day 10, you're still not having a lot of sinus congestion, there's going to be an antibiotic at the pharmacy ready for you on day 10. So you don't have to come back and see me, pay another copay, but I'm not going to fill it put future date it for the pharmacist. I'm not going to fill it until 10 days out from first symptom. And the hope is that most people are going to be feeling better by days 7 to 10 of the illness. And that's kind of the time frame where if it's lasting longer than that, it's appropriate to consider doing some sort of an antibiotic therapy for it. Because if it were a viral illness, it should resolve, caveat being not bronchitis. I hope this is helpful for you guys. I hope that this helps you guys understand my approach, my thought process for when somebody comes in with a common cold or flu syndrome and how I like to manage those. If you guys have any questions down below, leave a comment. And I'd really like to try to get to 100 subscribers in the next couple of weeks here. I think I'm like 86 or 89. So it'd be really cool to see if we could bump through to 100 subscribers. This has been a new project for me, and it's just something I do on the side for fun. I'm not trying to make any money at this or be famous or anything. I'm just trying to put some information out there that people can find beneficial. So if you have anybody that you think would enjoy this content, please just share your favorite video of mine with them. I'd really appreciate that, and we'll see if we can get some more subscribers in here. Have a great year, guys. Happy New Year. I hope you had a Merry Christmas, and we will see you in the next video.